Good afternoon, everybody. Welcome back to the Health and Social Services Subcommittee. I'm Delegate Emily Shetty, Chair, joined by our awesome Vice Chair, Delegate Dana Jones, and some of our members this afternoon. Sorry, we're at that stage of session where it's lots of running. So we'll start. Today we've got the Social Services Administration budget within the Department of Human Services. Lots of good content to cover. So we'll go ahead and get rolling with our Department of Legislative Service analysis. Welcome, and you can begin when you're ready.
Thank you, Madam Chair. The operating budget for DHS Social Services Administration increases by $11.8 million, or 1.5%, to a total of $791.2 million in fiscal 2026. Moving on to performance analysis on pages 5 through 7, DHS usually reports measures of child safety, child placements, and adult safety measures that is included in the performance analysis section. However, DHS did not include actual data for fiscal 24 and reported that it was unable to provide the data due to concerns about reliability. DHS should comment on the efforts that it will take to improve the reporting of these measures. DLS recommends adding budget bill language restricting funds pending submission of this data. On page 8, we have the proposed deficiency. Fiscal 26 budget bill includes proposed deficiency of $47.3 million for Social Services Administration, $18.5 million in general funds, $0.4 million in special funds, and $28.5 million in federal funds. $38.3 million of the deficiency is for foster care fiscal 25 shortfalls, $8.1 million for foster care fiscal 24 shortfalls, $1.4 million for contractual services for the foster care rate reform, and a reduction of $500,000 to reflect projected overtime payments within child welfare services. Exhibit 3 on page 9, we have the overview of agency spending. The largest chunk is for foster care maintenance payments, which is about $395.6 million, or 50% of the total budget. The second largest portion is for personnel expenses, which is about $297.6 million, or 38% of the total budget. Within personnel, the largest area is for child welfare services. Exhibit 4 on page 10, we have the proposed budget change chart. Fiscal 26 allowance increases by $11.8 million compared to fiscal 25 working appropriation. The largest increase is primarily due to increase of $14.2 million in regular personnel expenses, excluding cost associated with proposed deficiency appropriation related to fiscal 24 shortfalls. The fiscal 26 allowance for foster care maintenance payments increases by about $7.2 million. On page 11, we have a discussion on the implementation of new foster care provider rate structure. DHS began implementation of the new rate system in fiscal 25, which applies to institutional providers. The revised rate structure includes 2 sets of rate programs for direct and clinical care. Exhibit 5 on page 13, we have the fiscal 25 residential child care provider class rates compared to fiscal 24. Depending on the service class, the increase in daily class rates ranges between $66 to $679. However, for class 5, the rate decreased by about $446. Exhibit 6 on page 14, we have the average monthly payments for purchased institution. The average monthly payments increased by 19.5% in fiscal 25 prior to the implementation of rate reform. Following the rate reform, average monthly payments further increased by 19.2%. Purchased institution increased by $2.4 million in November and further increased by about $500,000 in December of fiscal 25. Exhibit 7 on page 15, we have the total purchased institution expenditure estimates. DLS estimates the total annual cost for purchased institution in fiscal 26 will be $170 million, reflecting an increase of $50 million from fiscal 24. DLS estimate for estimate based on the 2-month data available since the implementation of rate reform is about 22.5 million higher than DHS estimates. On page 16, we have a discussion on the status of the Medicaid state plan amendment. DHS indicated that Maryland Department of Health was expected to submit a draft state plan amendment with an effective date of July 1st, 2025. However, fiscal 26 allowance does not include funds through Medicaid for foster care. DHS should comment on when the Medicaid claims are anticipated to begin for residential interventions for children in out-of-home placements, and why the anticipation of these funds were not accounted for in fiscal 26 allowance. DLS recommends adopting committee narrative requesting an update on the second phase of rate reform, as well as an update on the number of youth served by the new foster care provider rate structure by class type and cost by class type in fiscal 25. Exhibit 8 on page 17, we have the foster care caseloads data. In fiscal 2024, the overall caseloads declined by 6%. Fiscal 25 data through December 24 shows that the number of youths in out-of-home placements paid by DHS have increased slightly by 0.3%. Exhibit 9 on page 18 shows the subsidized adoption and guardianships. The average monthly number of subsidized adoption decreased by 1.2%, and guardianships increased by 2% in fiscal 24. Exhibit 10 on page 19 shows the caseload projections by placement type. DLS estimates that overall placements will decline slightly in fiscal 25 and increase slightly in fiscal 26. Exhibit 11 on page 20, we have data on placement costs for 3 most expensive provider foster care placements. Average monthly placement cost for purchased institution increased by 3.2% in fiscal 24 and have increased by additional 27.4% during the first half of fiscal 25. Exhibit 12 on page 21, we have the foster care maintenance payments program expenditure forecast. DLS forecasts a shortfall of 5.2 million in fiscal 25, of which the general fund share is 21.2 million. In fiscal 26, DLS projects a deficit of 7.4 million, of which general fund share is 10.4 million. The forecasted shortfall in fiscal 25 and 26 is mostly driven by increase in purchased institution cost, as well as a different assumption of Title 4E availability for fiscal 25. On page 21, we have a bold comment. DLS finds that nearly 20% increase in rates for institutional providers in fiscal 25 under the new rate setting methodology is not affordable given the state's budget outlook. DLS recommends a 5% reduction to the rates for fiscal 26, which will save the state $8.5 million. DLS also recommends a provision to be added to Budget Reconciliation and Financing Act of 2025 to prohibit Interagency Rate Committee from providing rate increases for fiscal 26. On page 22, we have personnel data. The vacancy rate as of December 2024 is about 8.4%. Total vacant positions have decreased by about 120 positions since December 2023. The largest number of vacant positions is within Child Welfare Services Program. Moving on to issues, on page 23, we have a discussion on the out-of-home placements of children and youth. Exhibit 13 on page 23 shows the number of children in out-of-home placements across all agencies declined by about 19.8% between fiscal 2020 and 2024. Exhibit 15 on page 25 shows the out-of-home placements. The total number of children and youth in out-of-home placements increased by 5% in fiscal 24, following a 46.1% decline between fiscal 2020 and 2023. In addition to the data on out-of-home placements across state agencies provided by the Governor's Office, DHS usually publishes monthly out-of-home placement data on its website for children and youth in its care. The most recently posted data available is through December 2023. As of January 29, 2025, this data has not been updated. DLS recommends adopting committee narrative requesting reports containing monthly out-of-home placements data. On page 26, we have discussion on the family preservation services. DHS provides in-home family preservation services to children and families at risk of child maltreatment or out-of-home placements. Exhibit 17 and 18 shows the outcomes of the in-home family preservation services. Issue 2 on page 28, we have discussion on the evidence-based prevention practices implemented under Family First Prevention Services Act. Committee narrative in recent years has requested DHS to provide and report on this issue. DHS reported that 19 jurisdictions have implemented at least one of the 4 practices, and a total of 530 families were served. DHS submitted a revised public assistance cost allocation plan in December 2020 to allow DHS as necessary to claim reimbursement for prevention services. DHS should comment on the status of the approval of revised cap and the cause of delays in approval. On page 30, we have a discussion on the evaluation of outcomes for participating families. DHS reports positive outcomes from the evidence-based practices. On page 31, we have discussion on the qualified residential treatment programs. The FFPSA also included provisions amending the eligibility for federal reimbursement for certain non-family placements. To be eligible for these federal reimbursements, non-family placements in child care institution are limited to 2 weeks unless the program is designated as a qualified residential treatment program. The number of QRTP designated providers remained at 6 as of December 2024. DHS should comment on planned future efforts to solicit applications for additional QRTP providers. DHS has previously reported that they are working on establishing appropriate processes to claim federal Title 4E reimbursement for funding of non-family-based placements. DHS should comment on the status of this process as well. Issue 3, we have a discussion on the child welfare caseload and staffing report. In recent years, DHS has been requested to provide report on caseload to staffing ratios. Exhibit 19 on page 33 shows the Social Services Administration had 316 more caseworker positions and about 19 more supervisor positions than necessary to meet the Child Welfare League of America standards based on September 1, 2024 personnel data. DHS has reported that it is in the process of developing a child welfare case workload assessment procurement. DHS should comment on the estimated completion timeline of the child welfare workload assessment. DLS determined the information that was provided in response to 2024 JCR compiles with the language restricting the general funds, and DLS therefore recommends the release of $250,000 withheld in general funds and will process a letter to this effect if no objections are raised during the budget hearings. DLS also recommends adding language restricting funds in fiscal 26, pending submission of the report with the data as of September 1, 2025. Issue 4, on page 36, we have discussion on the hospital overstays for children and youth in out-of-home care. In recent years, DHS has been requested to submit data on youth in out-of-home placements served in hospitals. Committee narrative in 2024 JCR requested that DHS provide an updated data. The report was due on December 1st, 2024, but was not submitted until February 6th, 2024, and hence has not been included in this writing. DLS recommends adding language in fiscal 25, withholding funds until a report containing the data through September 2025 is submitted. Issue 5 covers child fatalities involving child abuse and neglect. Exhibit 20 on page 37 shows the data for calendar 2017 to 2021. As of December 11, 2024, there were 20 child fatalities that involved child abuse and/or neglect. DHS was unable to provide jurisdiction-level data as it has provided in the past. DLS recommends adopting committee narrative requesting DHS provide child fatalities data by jurisdiction. Starting on page 38, we have the recommended actions. The first recommended action restricts fund pending submission of the data related to CWLA caseload standards. Recommended actions 2 restricts funds pending submission of a report with data related to hospital stays. Recommended action 3 restricts funds pending submission of a report with data related to hotel stays. Recommended action 4 restricts fund pending submission of the managing for results data for fiscal 2024 and fiscal 2025. Recommended action 3 adopts narrative requesting update on implementation of provisions of the Family First Prevention Services. Recommended action 6 adopts narrative requesting data on child fatalities where abuse or neglect are determined to be a contributing factor. Recommended action 7 is an annual language. Recommended action 8 reduces general and federal fund within foster care maintenance payment. This is associated with the 5% reduction for institutional providers. Recommended action 9 recommends adopting narrative requesting update on child welfare services data. Recommended action 10 adopts narrative requesting update on the implementation of foster care provider rate reform. Recommended action 11 adopts the committee narrative requesting data on costs associated with placing youths in out-of-home placements in hotels. Recommended actions 12 and 13 are annual languages. That concludes my presentation, and I'll take any questions you may have.
Thank you so much for your thorough analysis. Do any members of the subcommittee have questions? Great, thank you so much. We'll now bring up our DHS panel. Deputy Principal Secretary White, if you would like to join us, and anyone else you'd like to bring from your team, you can begin when you're ready. Thank you.
Good afternoon, Chair Shetty and members of the subcommittee. For the record, I'm Carnitra White, and I serve as the Principal Deputy Secretary of the Department of Human Services. We would like to thank Governor Moore, Lieutenant Governor Miller, the Department of Budget and Management, and the budget committees for their support. We're grateful to our budget analyst for her budget, I do that every time, analysis. Joining me today at the table is Dr. Algis Studstill Jr., who is our Executive Director of the Social Services Administration, as well as our Acting Chief Financial Officer, Jessica Smith. We also have members of our leadership team present in the audience, and I'd like to point out our Director of Dorchester County Department of Social Services, Jen Dubois, as well as our Director of Howard County Department of Social Services, Geneva Rowe. While you have our written testimony, I'd like to highlight a few items, and then we'll go into the issues raised in the DLS analysis. As I mentioned in the overview hearing, in December 2024, we launched a bold new approach to strengthening family connections. We call it Family Matters. Family Matters reflects our belief that every child deserves a safe, loving, and stable home with people they know and trust. I like to say every child deserves to grow up in a family, and preferably the family of their own. Family Matters shifts our culture and practices across the agency to strengthen and support family relationships. The enactment of the 2024 kinship law allows us to do two things: offer new resources and training that empower kin caregivers to meet the needs of the young people they love, and to prioritize kinship care and facilitate lifelong connections for youth in out-of-home care. When we began this work, only 24% of our youth were placed with kin. As of Monday, February the 10th, 27% of our youth were with kin. We're making improvements, and we will continue to strengthen the work that we're doing to improve family relationships. Now I'd like to talk a little bit about our work to reduce hospital overstays. I know you often hear that we are not proactive in the work to reduce the number of youth in hospital overstays and hotels. However, we've taken steps to limit the number of youth who experience hospital overstay by addressing systemic gaps and increasing communication as well as collaboration. This work requires us to be innovative in our approach and our work with our partners to meet the health needs of our youth. As a former local director of social services, I was the director here in Anne Arundel County for 8 years. I can attest to the efforts that go into identifying an appropriate placement for youth who's in an overstay. Let me highlight an example for you. A youth came into care who was hospitalized for aggression, inappropriate behaviors, and cancerous tumors. There were challenges finding a post-discharge placement, due to the complex needs of the youth. Unfortunately, multiple providers denied placement. Our local department team worked collaboratively with our SSA team to identify alternatives. SSA and the local DSS partnered with the local school system for IEP updates as well as educational services while the youth was at the hospital. We collaborated with our state agency partners, Behavioral Health Administration, as well as Developmental Disabilities Administration, held interagency staffings regarding the needs of this young person and how we could meet their needs. Through these efforts, a new enhanced behavioral respite program was created. The youth was accepted into the program, and as a result, 6 additional beds were developed and are available in our state for youth with complex needs. When we have a youth facing complex situations and difficult placements, we don't give up. We work tirelessly to identify an appropriate placement to meet the needs of the young people we serve. We're building on and continuing this vital work in 2025. As you read in our written testimony, on February 26, 2025, we had 16 DH youth in a hospital overstay and 28 in a hotel. However, as of Thursday, 12 youth were in a hospital overstay. So what you see is that's 12 too many. We all can agree to that. But I hope you see that the efforts that we're taking are producing results. In fact, last year, this time, there were 21 youth experiencing a hospital overstay and 54 youth in hotels. Of the 12 youth currently experiencing an overstay, we've identified an appropriate placement for 6 of the youth. The remaining 6 have unique needs that are not easily met with systemic reforms. A key factor in addressing the systemic issues that we've identified has been our rate reform. Thanks to the support of the budget committees and the governor's office, rate reform went into effect October 1st, 2024. This $27 million investment created new category-based rate structure to incentivize our residential care providers to develop innovative programming when a youth has needs not met by our current continuum of care. Our new way of compensating out-of-home care providers is already increasing the range of services we can provide. This wider range of services reduces out-of-state placements, hospital overstays, and hotel stays. Prior to our administration, key data elements, I like to talk a little bit, we've talked about this in some of our other hearings, about our data integrity and transparency. Prior to our administration, key data elements, including hospital stays and hotel stays, were either not tracked or tracked manually. Unfortunately, we continue to discover challenges with the data reporting processes we inherited. Using existing budgetary allocations, we created a data office to modernize the agency's data collection and public reporting across the administrations. One of the priorities of our data office is to publish an interactive digital dashboard. And since we've talked about the data office and some of the work that they are planning to do, I thought we would give you a brief preview of what the dashboards will look like. So you'll see in this first slide, as you can see from that, this dashboard will include data points about placements, permanency plans, as well as other child welfare indicators. And then on the next slide, you'll see that that information will also be broken down by jurisdiction. So on this slide, you will be able to hover over the jurisdiction to get jurisdictional level data. The data will be published in a manner that promotes transparency while protecting the privacy and confidentiality of those that we serve. The dashboard will increase transparency with a reduced manual reporting while improving efficiency. With that, we'll turn our attention now to the DLS, the issues that were raised in the DLS analysis. And I will start with response to the first issue regarding our efforts on reporting on child safety, child placement, and adult safety measures. As I just mentioned, we're focused on data integrity and building out dashboards. Our priority is to ensure that any public-facing data is consistent, validated, as well as comprehensive. We will work with DBM to revise our MFR measures based on our new approach and to ensure that our measures align with our priorities. We will include reporting on the measures of child safety, child placement, and adult safety in our MFR submissions. The next issue is regarding the Medicaid claiming for residential interventions for children in out-of-home placements. We concur with the report requests. We continue to work in partnership with the Maryland Department of Health and the Department of Budget and Management on this compensation, on this component of our rate reform. The next issue is the recommendation for a 5% reduction in rates in the 2020 and 2026. We do not concur. As I mentioned in my testimony, rate reform is a key factor in assisting us in addressing the systemic issues in our continuum of care and our ability to prevent hospital overstays as well as hotel stays. The next issue is regarding the request for reports containing monthly out-of-home placement data. As I mentioned, this data will be available on our public-facing dashboards. And so we are happy to report all of that information on our dashboards, and we will provide information as needed to the committee. And now I'll turn it over to Dr. Studstill, who will address the next 6 issues.
Good afternoon. Regarding the DLS issue on updating the 5-year Title IV-E prevention plan, we have extended our 2020 to 2024 plan, which will allow us more time to refine our eligibility criteria for prevention services, as well as our expansion plans based on the FY 2026 budget. We plan to submit our amended prevention plan by June 1st of this year. Regarding the update on the revised cost allocation plan and the delays in approval. The cost allocation plan amendment, which became effective on January 1, 2020, was approved on September 30th of 2024. The next DLS issue regarding QRTP providers and Title IV-E reimbursement on federal claiming. We have revised how providers obtain a QRTP designation as part of our rate reform work in 2024. In FY 2025, 2 additional providers have received the designation for a total of 8 QRTPs in Maryland. We continue to work with providers to help them meet the QRTP requirements, and we anticipate that additional providers will receive the designation. Contingent on the passage of the FY 2026 budget, we are also making software changes to CJAMS on our MDThink platform to streamline data collection and automate reporting to improve federal reimbursement claiming. On the next issue raised by DLS regarding child welfare workload assessment and a report request, We are in the process of developing a procurement for the child welfare workload assessment and hope to have it out later this year. We are happy to provide the requested report, but ask for a due date of December 1 of 2025 to complete data processing. The next issue raised by DLS was a report on hospital stays data through September of 2025. We concur with the report request, but request a due date of December 1 in order to process the data. On the next DLS response regarding committee narrative requesting DHS provide child fatality data by jurisdiction. We request it be due January 7th of 2026. In addition, we request that the jurisdictional data not be broken down by age category as it brings in concerns about confidentiality of personal information in small data sets. For our responses to the DLS recommended actions, I turn it to my colleague, Jessica.
Good afternoon. We concur with DLS recommended actions with the following exceptions. Regarding recommendation number 6, as Dr. Studstill stated, we ask that the report be due on January 7th, 2026. Regarding recommendation number 8, DLS's proposed 5% reduction in fiscal year 26 provider rates. We do not concur for the earlier stated reasons on rate reform. Recommendation number 9, monthly data on out-of-home youth placement. We do not concur as we are taking an alternative approach via a public-facing dashboard with live data. Regarding recommendation number 13, Bertha language that fiscal year 26 provider rates may not increase past rates in effect on January 1, 2025. We do not concur for the reasons stated in our rate reform discussion. And this concludes our testimony. Thank you for your time, and we look forward to your questions.
Thank you so much, DHS team, for your thorough response. I'm going to start out with the first question, please. Just going back to our initial set of questions from last week about the Baltimore Banner article related to child maltreatment and data accuracy. So let's sort of start from where we began last week. DHS's administration analysis included notes about data accountability and data privacy. So I want to talk a bit about those findings of data privacy and data accountability found on page 20 and 21 of last week's analysis with the Baltimore Banner article, which reported that in FY23, 83 children died at the hands of their caregivers. Lily Price of DHS is quoted as saying the data reporting from DHS might not be accurate. And so I'm curious if you can share with us, please, some more information about how that reporting is inaccurate and what's been done to fix that data reporting problem.
Sure. Thank you, Chair Shetty. First, let me start with the fact that the protection of children is our highest priority. Ensuring safety and well-being of children is of ultimate importance to us. Any child death at the hands of abuse or neglect is tragic, and what we work for, I've been in this work for almost 32 years, believe it or not, but it's one of the things that if you have a social worker who has had a child who has died on their caseload, it is one of the most heart-wrenching things that you can experience. And so we continue to work to develop preventive measures and services to prevent child fatalities. We're working with national consultants to review and revise our child maltreatment fatality review process to align it with national best practices and safety science. We are a member of the Maryland State Child Fatality Review Team, who is tasked with reviewing all child fatalities and developing plans and strategies to address the trends. What we do know from research and national best practices is that infants and toddlers are at a higher risk of maltreatment-related fatalities. As such, we've been proactive in our approach to preventive measures. For instance, every case in which the department is involved, if there's a newborn or an infant in the home, caseworkers are required to discuss safe sleeping practices. If necessary, we provide pack and play to ensure safe sleep arrangements. With regards to your question around the inaccuracies in the data, child maltreatment deaths were overcounted in our previous federal reports. The child fatality counts for the National Child Abuse and Neglect Data System, which we call NCANS, should have only included fatalities with a substantiated or indicated abuse or neglect disposition. Indicated abuse or neglect findings in the case of child fatality do not necessarily mean that the alleged maltreater directly caused the death of the child. Frequently, the indicated abuse or neglect means that maltreatment may have been a contributing factor that made the death more likely. What we learned is that we were reporting, when we learned that we had data discrepancies, we manually reviewed to ensure that we were actually reporting the maltreatment fatalities when there was abuse or neglect. We were reporting all fatalities that we were investigating. Corrected reports covering the federal fiscal year 2024 have been submitted to NCANS this month. And we're also advised by our federal partners that we'll be able to correct the 2023 data. So that information will be submitted as well. What we learned through our manual reporting was that there were 47 child fatalities with an indicated disposition of maltreatment. That was a contributing factor in federal fiscal year 2023. This doesn't show an upward trend in maltreatment fatalities. Additionally, the number of youth reunified with family within 5 years preceding child fatality is below the national average. In 2023, there was one child that was reunified where there was a subsequent child fatality. One too many, but. Additionally, the number of youth reunified with family within 5 years preceding a child fatality death is, I'm sorry, I just said that. I get a little emotional when I think about the child fatalities. DHS works under the oversight and approval of the juvenile court. So anytime a child is returned home, it is in partnership with the juvenile court. In cases involving abuse and neglect, reunification happens when the court reviews the evidence and determines under Family Law 9-101 that there's no risk, no further risk, future risk of abuse or neglect. I would say, as a social worker, and Dr. Studstill has also done child protective service work, when we're doing this work, we're using best practice assessment tools to assess safety and risk of the families. We develop services and ensure that the family takes those services. We work very closely with these families to eliminate future risk of abuse or neglect. Through the federal law, our first plan has to be reunification. And so we work with the families and to ensure that they have the services and the resources they need in order to raise their children safely. We are committed to transparency, and we're in the process of making child fatality reports available to the public for the first time. Proactively sharing demonstrates our commitment to transparency in a way that the department has not previously modeled in the past.
Thank you. I know this is a really heavy topic and one that a lot of us can sort of connect to as either parents or guardians or aunts or uncles to littles. And some of these cases are extremely tragic. And so I commend all of the social workers and caseworkers that work on these really, really difficult cases. And I also really appreciate DHS's commitment to transparency and ensuring that the data reporting is accurate, that it's reflected correctly in our federal numbers as well. But more importantly, that we're doing something with that data, right? Not only is it important for us to know what the status of these cases are, But we have to be able to examine each case individually to see if this was preventable, what could we have done differently or better to protect the lives of future children who could be at risk of some similar fate. So I am heartened to hear about this review board that you shared earlier. I know, I think their task, if I'm understanding correctly, is to review each of these cases, provide updated data and reports on what happened, and sort of similar to the Maternal Mortality Review Board at MDH. I'd love to just get a commitment from you and MDH, I'll work with them as well, to try and get get some report language in to get them to review the most recent statistics and the most recent data, because I think it's been a little while since they've provided an updated report. So I hope to have your commitment to work together on that.
So working with the Child Fatality Review Board, the state board, as well as the local Child Fatality Review Boards. And the purpose of the state Child Fatality Review team is to prevent the deaths by developing and understanding causes and incidents of child deaths, developing plans and implementing changes within agencies that are representatives on the board. And we are one of the members of the board, so.
I look forward to working with you and your team on a report or language for the budget on that. Do any other members of the subcommittee have questions? Delegate McCaskill, I see you flipping through your pages. Sorry. Oh, I'm so sorry. Please.
I'll be quick. So appreciate, good to see you, Madam Principal Deputy Secretary. Appreciate your department providing me information about the VSA and the response that you all had provided to DLS last year, December. I noticed as part of the VSA there were some agreements, particularly around modifications for E&E, and just wanted to know, I know we're in February, this was in December, but just any updates on what modifications and what potential cost of those modifications for your agency are looking like. If you could provide an update, I'd appreciate that.
Do you have that? We won't be talking about that. I can look in my data, but we will be talking about that in our
Okay.
which is scheduled for next week.
All right. So I'll see you next week then. All right.
Thank you, Delegate. Thank you, team. Delegate McCaskill.
Madam Chair, so great to see you all on the panel. So just for a point of clarification, I know I wasn't the best at math, but on page, just because it makes so many references to it, specifically on page like 5 and 6 and 7, yes, when it says per 100,000 days of foster care during a 12-month period. So I know that there are no more than 365 days in a 12-month period. So I'm just curious because it mentions it quite a few times, but then it goes back to 1,000 days. So just, we could follow up on it, but it was confusing me as I read, but I just wanted to make sure for point of clarification that I wasn't that bad at math.
Yes, we will follow up on the data for you.
Perfect. Okay, I have an easy question, I think. You know me, I'm always asking about personnel questions. And so I think my page 2, about the vacancies decrease. Okay. All right. While page 2 notes that there has been a decrease in vacancies, the remaining open positions are still 219. That is 58 positions more than expected turnover, and this accounts for 8.4% of all authorized positions. Could you just give me comment on what is being done to fill those roles?
Sure. Sure. This is in our child welfare area. And so in our child welfare area, we are continuously recruiting. That's an open and continuous recruitment for child welfare staff. As you know, we are in competition a lot with telehealth now, and a lot of the staff that we hire are licensed social workers. And so we have been putting in new strategies to go to BSW level staff as well. And so we are working diligently. We have reduced the number overall of our vacancies. When we began in 2023, we had a 15% vacancy rate across the department.
Right.
And now we are at a little under 8% vacancy rate in our department.
Okay.
So we have put in lots of measures to continuous. I will say that child welfare is one of the hardest to recruit, but we continue, and we are making strides.
Okay, perfect. Thank you, Madam Chair.
Thank you, Delegate. Thank you, team. Vice Chair Jones.
Thank you so much, Chair. I have a question regarding electronic health passports. There was legislation back in 2018 on this. Basically, it's a centralized healthcare monitoring program that states that it is the intent of the General Assembly that the Department of Human Services established a central data portal in partnership with the Chesapeake Regional Information System. It, immunizations, medical databases, and that way, because we know that kids, right, they barely have a bag that they show up with sometimes, and having that medical passport all together and that healthcare passport is so crucial. So I was wondering if you could provide an update on the status of the centralized data portal and the electronic health passport, as well as maybe a time frame when this might all be completed.
Sure. So we have made some changes and updates to our electronic CJAM system in order to make sure we have all of the health information electronically there. And we're still working on procurement in order to have the integration of the information to come. And I'll let Dr. Studstill talk about some of the efforts that lately we've been making as a result for the electronic passport.
Thank you, Principal Deputy Secretary. So currently there is a paper health passport, but we have been working between our partners with CRISP, as well as looking at not only are we able to get the data integrated into our CJAM system, but to also allow for any of our caregivers, whether it's a kin placement, a foster parent, a grandparent, to also have access to that portal, so that whenever health information gets updated, whether by the caseworker or the hospital, the caregiver also sees that information in real time, and they're able to make their own notes, as well as ensure information is shared between all of the individuals that are working with that young person.
Right, it's not all completed yet, though,
No,
right?
ma'am. No, ma'am. So
Right.
we're working with our procurement team, as well as our MB Think partners. So hopefully that procurement gets released soon. I know the paperwork is currently in process. Our timeline, we're looking to hopefully have something by next summer in 2026. And so the paperwork is being developed so that we can work with the vendor to actually build what needs to be built.
So over a year out?
Yes, ma'am.
Yeah, okay. Are there any other barriers that we should know about when you're talking about integrating information from CRISP and Medicaid and everything else? Is there anything else that we should know about, we can be helpful with in any way, shape, or form?
So I think at this time, we've tried to unravel a lot of those challenges and barriers, and we stay committed to updating you if there are additional challenges as we develop in the procurement and getting it out on the street.
Yeah, a paper copy to follow children is just, I mean, with your experience, you know.
Absolutely.
Yeah,
That is
absolutely.
just great. Thank you so much, Chair.
Thank you, Madam Vice Chair. Thank you, team. I have two questions. So I want to talk a bit about child safety. So the let's see, on page 11, there's a line item about child abuse prevention and treatment contract. Can you share a little bit about this initiative? Where is it being deployed? Page 11.
Evidence-based partnerships.
Yes, Chair. So that particular line item includes all of our prevention and treatment contracts. So whenever we're working with the family, whether it's through alternative response, in-home, family preservation, we always work to have evidence-based practices, which allow for us to do federal claiming through FFPSA. And so this particular line item is really making sure that we're able to serve children in their homes, to do all that we can to prevent a removal, prevent them from entering foster care. So that category would encapsulate all of those prevention-related services.
Okay, got it. And it's being deployed all across the state or in specific jurisdictions? How is it?
We can get you the specific details.
Yeah, that'd be great. Okay,
yes.
I appreciate that. My last set of questions is on out-of-home placements. So on page 23, it mentions that out-of-home placements have declined by 19.8% between FY20 and 24. Could you add some commentary on that? Can you tell us a little bit more about the decline? Is that because of the Family First Initiative success, or?
Yeah, I would say that it's both because of our efforts to do upstream work and work with families to prevent removal, but also and I would have to go back and look at the number of children who actually exited our system. And so as we exit more children to reunification, guardianship, and adoption, as you saw in the analysis, also our guardianship numbers have risen. And so as more children leave and less children come in, then you'll see a downward trend.
Got it. Okay, thank you. And then moving to page 24, Exhibit 14. The total youth and hospitalization category is 441. That's not all of the children in hospital overstay cases, right? Can you tell us more about what that is? Would you like to follow up?
Yeah, I'd like to follow up just
Okay.
to make sure we know. I believe this may be the total number of children who had any hospitalization during the year. So
Got it.
if
Okay.
they went in for surgery, if they went in to the ER for anything.
Okay, got it. Thank you. And I know I appreciate the department's commitment and the comments on the hospital overstay challenges. I think that there may still be some discrepancies, however, between what the hospitals are seeing on the ground and what the department is sharing with us. And I think part of it might be because of just the numerous agencies, right, that work with these lovely children that are in hospital overstay status. So I'd love for us to get to the bottom of that number so that we're identifying what the appropriate options are. Where can we really focus our efforts? In the DLS analysis, there was a lot of great detail placed on the classes of different placement options available. I'd love to see if do we need an additional class if there are a group of individuals who are facing hospital overstay status, who have such complex needs that cannot be handled by any of the 6 classes in the current system. What do we need to do to get to a place where we can really ensure that children are in the appropriate care setting for their needs? So let's continue that work together offline, please. Thank you, ma'am. And then I see on Exhibit 14 on page 24, so the one we were looking at just now, further down on the chart is a category called Other and Unknown, and there are 408 children in that category. What does that mean? Who are these children? Where are they?
So oftentimes, these children is either the placement hasn't been correctly entered. Children are on runaway status, have been on runaway status throughout the year, or they're in a living arrangement and not in a placement setting. So they could be in a living arrangement and not in a placement setting. So we can go back and give you actually the breakdown of those.
Yeah, that would be great. I just think as we're thinking through solutions to help ensure that these children are getting the care that they need, the educational support that they need, that we know where they are and we're able to match the supports required to their current needs. So thank you for that. I see Delegate McCaskill has a second question. Go right ahead.
Thank you, Madam Chair. I think you hit part of where I was thinking around some of the discrepancies with some of these numbers and the unknown. So we'll wait and have a further discussion about that and follow up as we need to. But just to make sure, it could be because it's Monday. But I understand that for many years that the child welfare was published in a monthly report and that we haven't had that. Is that going to also be in the new dashboard that we should be looking for?
The placement data information will be in the new dashboard, so you'll be able to see the actual number of children who are in our foster care system, where they're placed, so whether they're placed in a family home, a group home, independent living, RTC. You'll be able to see the placement, the permanency plan, so whether there is adoption, reunification, guardianship, is the plan of the youth, and then there'll be many other, there are other categories. I think there are about 7 different dashboards that will be available, and we hope to have this available by the beginning of March.
Oh, perfect. So the monthly welfare report is not being discontinued, it's just being placed elsewhere. Okay,
Dashboards and the links as well.
Perfect.
And we would like to do that so there's consistency in the data that we're reporting across time frames, because what we see sometimes is that we'll report data for this date, and then someone will ask it for a different date time, and then there looks like there's discrepancies in the data. And so having consistent dating at times by which we report is also helpful to be consistent in the validation of the data as well.
oh, perfect. Thank you, Madam Chair.
Thank you, Delegate. Thank you, DHS team. I see no further questions from the subcommittee. So if you wouldn't mind, we have 5 witnesses who have signed up for public testimony. As is our custom, we love to request that our agency partners stay and listen, please. Thank you. We have 4. We have 4 witnesses. Thank you, ma'am, and team. Thank you. So for our second panel, we're going to call up the 4 individuals, I misspoke, I apologize, who have signed up. Robert Bassler with Arrow Child and Family Ministries, Therese Hessler with the Maryland Association of Resources for Families and Youth, Shannon Hall with the Community Behavioral Health Association of Maryland, and Mary Towns with AFSCME Local 112. So whoever of those 4 are here can join at the table. You can go in whatever order you wish, and 2 minutes, please, per person. Thank you.
Good afternoon, Madam Chair, Madam Vice Chair, and members of the committee. For the record, my name is Teresa Hessler, and I am here today representing the Maryland Association of Resources for Family and Youth, also known as MARFI. Our members represent over 200 programs that serve Maryland's most vulnerable children in foster care, adoptive services, group homes, and independent living programs. The need for continued provider rate reform is urgent. Without proper funding, providers struggle to retain social workers, behavioral health professionals, and foster parents, leading to instability in placements and gaps in care. Additionally, the funding increases for treatment foster care and independent living programs are essential. Youth with complex behavioral and mental health needs require intensive, structured support. However, current reimbursement rates do not reflect the true cost of providing these services. Without increased funding, agencies are forced to limit placements or shut down programs, reducing essential options for children in crisis. We are asking that no cuts be made to what has been proposed in this budget, as underfunding has led to devastating consequences, such as children being placed in hospitals, motels, or unlicensed facilities that do not meet their basic care needs. We recognize the financial challenges facing the state, but investing in our children is investing in Maryland's future. Thank you.
Thank you. Go right ahead.
Good afternoon. I'm Shannon Hall, Executive Director of the Community Behavioral Health Association of Maryland. We represent mental health and addiction treatment providers across the state. Within the child welfare continuum, our members deliver family preservation services, treatment, foster care, residential group homes, and residential treatment centers. Like my colleagues, I'm here to ask you guys to pass Governor Moore's budget, fully funding rate reform as proposed, and reject the 2% cut. The rate recommendations in child welfare have been developed through a transparent process involving stakeholders facilitated by nationally recognized firm PCG that we've worked with extensively. They've worked across states. They've evaluated provider expenses and they've projected costs. To your point, Chairman Shetty, around developing a stronger clinical continuum of care for Maryland children so we can continue progress, making sure that children don't overstay hospitals, aren't placed in hotels, and are actually placed in settings that promote their path to mental well-being and restoring families. So please pass the child welfare budget as proposed by Governor Moore. Thank you.
Good afternoon, Chairperson, Vice Chair, and members of the Budgeting Committee. My name is Mary Towns, and I have been with the Department of Social Service for over 30 years. I am also a proud member of the ASME Local 112. Baltimore City Department of Social Service, where I work, is one of the largest child welfare populations in the state. And yet we face several staffing shortages, a lack of resources, a critical gap in service. If we truly want to support our youth, we must act now. Within my 30 years of being on the front line, I have seen the struggle our children face. We need more structured educational programs, mentorship, and intervention methods to provide the youth before they end up in the justice system. We also need an overnight lockdown facility for youth who runs away or refused placement. This would provide a safe space where trained staff can intervene before these children fall deeper into crisis. Additionally, we must strengthen partnerships with law enforcement, faith-based organization, and mental health professionals. Programs like police mentorship, church outreach, and educational classes for youth can redirect lives before it's too late. Hospitals should serve as a safe haven for youth in crisis, and no child should be released back into the community without a proper evaluation. But none of this is possible without additional staff. Our case managers, social workers, and mental health professionals are overwhelmed. Without proper support, we are failing the very youth that we are meant to protect. The state must find a way to raise revenue for staffing throughout the state. The cost of doing nothing is far greater than the investment required to create real change. Let's act now for the safety of our youth, our community, and our future. Thank you.
Thank
for
you.
your time.
Thank you so much. Thank you,
You're welcome.
advocates, for being here today. Do you have any questions? I see Delegate Acevedo.
Thank you, Madam Chair, and thank you all for your testimony. I completely agree with each and every one of you all around the investments, no cuts, and especially appreciate the last panelist's testimony about investing in our young people in the next generation. You mentioned something that piqued my interest, that I'm curious of the entire panel. You mentioned in your testimony that we have to find ways to generate revenue, and I completely agree with you, right? We have a deficit. And I'm just curious whether your organizations or whatever coalition you all are in are also advocating for the necessary tax reforms that are needed so that we could get that revenue to make these kinds of investments and not the kind of cuts that we want to see, right? We have an archaic tax code. There's a lot of things that we still need to do. And I'm just curious if there is a balance in your advocacy in that, one, yes, we need to make sure we're funding these programs and agencies, do not disagree, but also ensuring that we are raising the necessary revenue so those who can and should be paying more are doing that. And if that's something that you're also communicating to our colleagues, Democratic and Republican. Just curious. Anyone can answer, please.
Thank you for the question. We're Community Behavioral Health Association is part of the Behavioral Health Coalition, which has been advocating for that more broadly. So I can, we can follow up with you on some of the specific efforts around that. But I would just note, we have, as you guys I think are well aware, during the pandemic, the mental health needs of young people in Maryland rose significantly. And over the last couple of years, the state has made significant investments in trying to meet the needs of where our young people are at. So we think continuing those investments is really critical to Maryland's long-term strategies, and making sure that we have the revenue to do so is critical. So thank you.
And on the behalf of Baltimore City, I would like to say we do need more staff because I work at extended hours and I see the youth come in and I see them leave. It's nothing we can do if they want to leave, but if we had something in place where we had more mentorship, more social workers, more people in place, even churches, somebody that can get to our youth, somebody that can talk to them. And I believe the mayor had spoke about this before, Mayor Brandon, about getting involved. So it might not cost as much if people would get involved.
Thank you so much for your question, Delegate, and for your responses, advocates. Seeing no further questions from our subcommittee, we appreciate you coming and joining us. We have now completed our consideration of the Department of Human Services, Social Services Administration budget. So our subcommittee meeting is adjourned. Thank you.